Okay, it's 6 o'clock, so I will, we can get this underway. Welcome to our meeting here tonight to meet with you, and I guess maybe introduce yourself and then we can get into it. And if council has any other questions after or during the presentation, then you can field those. We'll have to probably run this no later than, say, 10:02 or 5:02 before our meeting, if you don't mind.
Yeah, no worries.
Okay, so go ahead.
Excellent.
Welcome.
Thank you, everyone. So I do have a loose agenda, but I really want to be clear that I'm just here to hear from folks and to answer any questions that you might have about our organization. But to get started, I want to thank everyone for coming early, because I believe you typically don't start till 7, so I appreciate everyone taking some time out of your family life to come early and spend some time with me. I've been chatting with Lance a little bit, and I asked to come and spend some time with you folks just to clarify some of the stuff. There's lots of misinformation about what we do, and so I wanted to provide the opportunity to clarify what it is that we actually do, and to talk about what challenges you folks have with what we potentially do, and to clear up misinformation that's out there, because there is some misinformation about what we actually do. For example, there's misinformation that we teach people how to use illegal drugs, and we absolutely do not ever do that. So I want to make sure to give folks the opportunity to ask me any questions or get clarification on anything that you folks may have heard in the community, or maybe some of the discourses that you may have heard directly yourself, so that I can help to clear that up. As far as introductions go, I do actually have a really long introduction, but I'm going to give you a really quick introduction on who I am. So my name is Shohan Illsley. It's spelled Shohan because this doctor named Dr. Skelly in northern Manitoba delivered me and told my mom to spell my name that way, and she did. I'm not Irish, but it's an Irish spelling, so I get this Irish name. But I was born in the Paw, and I grew up in the Paw, in Opaskwayak Cree Nation, and also Churchill, Manitoba. So my mom and my stepfather are Joy and Ahab Constant from the Paw and OCN, and my father is Bruce Martin from Churchill. And so those are my two home communities, but I do reside in Winnipeg, and I have lived there now since 1996 when I moved down there. So I'm a city girl now, but my home fires burn strong coming to the bush. And so yesterday I was adamant about beating the snow, because there was rumor that it might come yesterday before I made it here. But as soon as I hit the bush line, I'm always happy coming up here. I'm also a winter baby, so the snow today also made me really happy. And in Winnipeg, we're seeing plus 10 temperatures, so no snow. We might get some, they said, tonight. I'm also a mother, and I have 4 children, and I do want to be clear, my children are all, and my husband are all status to Sapataria Cree Nation, and so his family, his mother's Edna Stevens, who's from Birch River area, and his father's Robert Bushy, who's from Barrows and that kind of area. So my husband is from this region, but again, we live in Winnipeg. I'm also the executive director at the Manitoba Harm Reduction Network, and I have been there for 17 years now, just over 17 years. And so I've been doing this for a long time, and when I first started, we were a Winnipeg network, and we have now expanded to have sites throughout the province where we work really hard to support people who use substances and are impacted by substance dependence and other marginalizations like homelessness or poverty, things like that. How do we provide supports to connect them to services, including treatment services or healthcare services, or mental health services or housing services? What is it that we can do to bridge some of those gaps? Because we know there's lots of reasons people don't access services. So that's kind of like an overview. I also want to be clear that my priority as a director really lies in improving access to services in rural and remote communities. As somebody who grew up in a remote community, we know access to services looks a heck of a lot different in our rural communities than they do in Winnipeg. And Winnipeg's not great, but our rural communities struggle even more. We don't have the same resources in our rural communities as you guys are well versed in. And so that's kind of where my focus has always been in the work that we do, is how do we improve services in rural communities, recognizing there's no treatment very little treatment in rural communities. And so what can we do to support people when there's not access to treatment, and what does that look like? And then thinking about outside of the box, what are all the ways that treatment can look like? Like, how do we get people into environments where they can heal when treatment is not an option? Because what we know is that if we can create environments where people can heal, their substance use actually changes. So how do we do that when treatment's not really an option? I'm happy to talk about the treatment system if folks want to see the reality of it, but in short, what I want to be clear for folks is that we had a Virgo report done here in Manitoba. The Virgo report is now 5 years old. It was released right before the pandemic hit, and that Virgo report was commissioned by Manitoba Health that looked at our mental health system and looked at what treatment, access to treatment looked like in Manitoba. And what that report concluded was that Manitoba had one of the most archaic treatment programs in Canada. It also recognized that in Manitoba, in order to get access to treatment, it's on average 3 to 9 months waiting in order to get into treatment. And so that report really lit a fire for the government to say we need more access to treatment, and also we need more access to figuring out local solutions, because we know that problematic substance use is increasing, it's not actually decreasing. And that is an issue globally, like across Canada, we're seeing an increase in harms related to substance use. So it's not unique to Swan River, it's not unique to Manitoba. It's actually something we're seeing across the country. So with all of that, I have lots of information, but I actually wanted to hear from you folks first to open up to say, what are some of the things you hear we're doing? What are some of the things you're curious about what we're doing? So that I can start to address what we actually do and what we don't do.
Okay.
Yes, go ahead.
Okay. Tanya Powell from the Overcharge and Prejudice Center. I have actually been to one of your conferences, and it was probably about 8 or 9 years ago when I first got into this role of Housing First. I'm a Housing First coordinator.
Oh,
my question is, what does harm reduction do here in Swan River? What does the harm reduction do here in Swan River?
excellent. Okay. So I want to, when I'm answering this, I want to preface this with saying Prairie Mountain Health does some harm reduction work, and then Manitoba Harm Reduction Network does some harm reduction work. And so what our work plan actually says, we have two components, main components to our work plan. The first one is to work with people who use substances and are impacted by colonial and structural harms, right? So we're not just talking about everyone who uses substances, we're talking about those who are the most marginalized in their substance use. And what we do is we work with those folks to say, what services do you need? What services are you not currently connected to? And how do we build environments where we can bring those services to you so that you can access them? So the peer group that we have here, so they host quarterly testing events. And those testing events are designed to bring public health out to the community, bring other mental health supports. 1 year we even had PAP tests available at an event. Foot care, wound care, a housing coordinator, EIA coordinators. It could be a whole bunch of different services, and basically host health fairs where people can go and start to get linked up to those services. So we host those every quarter, and we host it quarterly because the guidelines, the national guidelines for people who use substances when it comes to STBBI testing is to get tested quarterly. So every 3 months they should be getting tested. And so we host these events where we have service providers come, and the whole intent is to start to build relationships between the peers and those service providers so that peers will eventually go and access services at their site. So if CMHA is there and provides mental health support, they start to build some relationship, and then the individual will start accessing at CMHA over time once they build relationships. 2 to 3 weeks later, we host a post event, and at that post event, public health comes back and is able to give people their STBBI testing results. And the hope is to link people up to healthcare services if they have some positive tests. So whether that might be hepatitis C care, or HIV care, or syphilis care, or even just gonorrhea care kind of thing. So anything that they're seeing. Also, people might be getting additional blood work, so if there's any other challenges that the nurses need to talk to them about, the hope is to bring them together in those spaces. So that's one thing that we do. The second, oh, and then we also, I should be clear, we also work with that group to say, what other services do you need on an ongoing basis? So one of the things we're seeing right now in all of our communities is we're seeing lots of injuries. So lots of wounds on people, lots of infections, untreated, like cuts and stuff that over time when you're not showering and cleaning them will get infected. And so we work with public health to also offer things like wound care. And we do this because we want people to get treated when they have a wound or have a cold even, for example, versus them showing up in an emergency room when they now have a pneumonia or they now have our sepsis, right? Because if we can treat them over here when they're a little bit sick, it's more cost effective, but also it allows folks to get their needs met early on in their health status versus if they have pneumonia now they have to spend up to 3 months in the hospital kind of thing. So we also offer things like that. And then we also offer like coffee time and beading and like things to bring people in off the streets and away from loitering so that they can actually sit and be together if there's no option for them to gather in other spaces. The other flip of that is we also run local harm reduction networks, which are designed to bring together service providers that work with people who use substances so that we can do some capacity building. So for example, if Hep C is an issue in the community, we can train service providers on what hepatitis C is and then how do you refer your own folks over to Hep C care. That network also hosts community-based events. And so we want to do education outreach events. So for example, next week is it's now Indigenous AIDS Awareness Week, and then December 1st is World AIDS Day. So all over the province we'll be hosting community-based events to do some information around what is HIV, how to support our relatives who are living with HIV, and get information out into the community. And that could be a variety of things. That could be like a fair, it could be some radio announcements, it could be, sometimes there are parades or walks, like often on World AIDS Day we have a World AIDS Day walk. And those events really are structured around what are the national events. So February, for example, is Sexual Health and Reproductive Awareness Week. So we'll have a community event around that. We'll have one around May is Hepatitis C Awareness Day, Overdose Awareness Day in August, for example. So we structured around what are those national days and how do we bring that information and education to the community and then to the service providers who also work in the community. So those are the two big things we do, the peer stuff to engage peers in services, and then we also do the community-based stuff.
So, okay, I'll just come out there. Where is needles? The needles and everything else involved. That's
Yes.
the biggest question.
Excellent. And so part of our work, when we have RHAs that do supply distribution, then we work with the RHAs to also provide supply distribution. And so now all the RHAs do, at one point not all the RHAs had supply distribution, so we didn't always do that. Here in Swan River, the RHA does it, and so we do it. And we do it we could do, if we're in the office, we're not always in the office. It's not like a drop-in, we don't run a drop-in center. But if we're having meetings in the office, then folks can access supplies there. When we had some folks who were housed, we worked with public health to do the drop-offs at people's houses and drop off new needles, and then also sharps containers. When people became unhoused, then lots of the work turned to outreach. And then people stopping in at the office. So that's where supply distribution would be happening. And then at our events. So if we're hosting peer events, then we would have, public health would come and also provide supplies at those events.
Okay.
Do you think it's been successful?
So when it comes to supply distribution, so I want to be clear. There's harm reduction and there's supply distribution. And supply distribution, harm reduction is a model of how do we support people who use substances. Supply distribution is straight up just a health intervention to say, if we have people who are injecting drugs, how do we stop transmission of HIV and hepatitis C? So when you ask, has it been successful? We have lots of data that shows providing people new supplies and a new needle every time and teaching people how not to share supplies, all of that stuff, does influence or does stop transmission of hepatitis C and HIV. So when you ask, is it successful? It's successful to do what it's designed to do, which is stop transmission of HIV and Hep C.
That is the point. So I don't think anybody's arguing that the stats on that.
Right.
But do you think this local initiative of supply distribution has been successful for our region?
So it has been successful to stop transmission. During the pandemic, what we saw was when supply distribution, so prior to the pandemic, our rates of HIV stayed in the province, our rates of HIV stayed at 100, about 100 new cases a year for about 15 years. There was 1 year in there where our numbers went up to 121, and we were all alarmed to say, holy smokes, what's happening that our numbers went up. But they went back, and they hung out at about 100. During the pandemic, supply distribution stopped in the province because all of public health was mobilized to respond to COVID. And so in addition to supply distribution stopping, so did STD-VI testing. It was very hard to get tested for that, which meant people weren't getting treated, and when people aren't getting treated, we know treatment is prevention of transmission. Coming out of the pandemic, we have, it took us about 2 years to start to get supply distribution going again to the same degree it was prior. And what we are now seeing is there's been a significant increase in HIV and Hep C transmission, which has been attributed to that 2-year period where there was no supply distribution. And so now people are getting tested again, and we now are seeing HIV and Hep C rates that we've never seen in this province before. Which then tells us that removing and not having access to needle distribution had a role, there was a role of that, removing that had a role to play in what we're seeing now. And what we're seeing now, folks, just so you know, is that Manitoba has the highest hepatitis C rates in the country, and we are number 2 for HIV. And when I say we have alarming rates, the last numbers, we're going to get 23 numbers next week on December 1st. The Manitoba HIV program will release their new numbers. But in 2022, we saw, I'm typically don't forget numbers. I think it was almost 300 new HIV cases. And so remember, it stayed at that 100 for a long time, and then we saw this jump of 300, and we're anticipating well over 300 next week for the announcement. So for supply distribution, sure. When it comes to looking at, because what the challenge here, I think, is really publicly discarded needles. The number 1 cause of publicly discarded needles is public drug use. And so what we need to do is think about how do we prevent public drug use from happening. Because when people are housed, we don't see the same level of publicly discarded needles. We'll still see needles. I sent some evidence, I put some evidence on one of the Facebook pages, and I also put it on the Health Network page to show some evidence around publicly discarded needles and where we see an increase in publicly discarded needles. But I also want to be clear that if we removed all, and I should say the Manitoba Harm Reduction Network stopped doing supply distribution here about a month ago. So we are no longer doing supply distribution. We are still doing needle cleanup and spot checking hot spots and going out regularly to do needle cleanup. We also are doing more additional training on how to discard of your needles and how to pick up and discard of publicly discarded needles. But when we see an increase in publicly discarded needles, we have to back up and say, okay, what's the cause of publicly discarded needles? Because even when there's been 0 supply distribution, and there wasn't supply distribution in Manitoba at one point, when there's been no supply distribution, we still saw some publicly discarded needles that was directly connected to folks who were publicly using substances. So then what we want to think about focusing on is how do we reduce public drug use so that we can reduce publicly discarded needles. Does that make sense? I talk about this stuff all the time, so I want to make sure I'm making sense.
Anybody else?
I guess my question is, you're saying that the HIV, the 2 diseases are caused by a needle. Do you not think there's other causes to this?
Yeah, there definitely is other causes as well. So hepatitis C is blood-to-blood transmission. So hepatitis C is transmitted by sharing of needles, sharing of injection equipment, and unsafe tattooing. those are the two primary ways. There is a little bit of sexual transmission, but there has to be blood present and an open wound on both sides. So that's the way Hep C is transmitted. And when it comes to HIV, HIV is transmitted injection drug use as well as sexual activity. And when we get the report next week, we will find out exactly what the risk factors are. And in Manitoba, I want folks to know, in Manitoba, HIV, for a few years there, the #1 mode of transmission was heterosexual sex. And it has now increased for injection drug use as a mode of transmission. So those are the two ways that they are transmitted.
So it's increased with the free needle?
It increased when we saw 2 years of no needle distribution happening. And then I want to be clear, no needle distribution and no treatment happening. So people were getting tested and treated. And if we test people and treat them, if people have HIV, for example, and they're getting treated, they will not transmit HIV. And if people have Hep C and get treated, it's cured, they can't transmit it then. So during that window of time, we also saw people not getting tested and not linked into care.
Councillor Medwid.
During our town hall with PMH, two highly respected doctors both spoke to the fact that when they work with our vulnerable people through the clinics, they are less likely to present to the ER. They are most likely to show the positive tests and or higher health needs as compared to those who are not taking advantage of harm reduction services.
Mm-hmm.
They are usually the ones presenting to the ER with sepsis, with the open wounds that require IV infection treatment of 8 weeks or more, and or being air-vac'd to Winnipeg or Brandon for treatment or services. So they spoke to the fact that when people are using harm reduction services, they are less likely to have the severity of health problems and risks compared to those who are either choosing not to or just absolutely against using harm reduction services. So the lack of use for harm reduction does, and that's kind of correlating with what I'm hearing right now, because when they didn't have the harm reduction to the extent during the epidemic and no testing, no limited services because the focus was COVID, we come out of that and we're seeing an increase.
Yeah. And if I can add, so I want to be clear, where the docs were talking about supply distribution. Harm reduction is a full model of care, right? We're talking about supply distribution. And so what the research shows is that when people inject drugs, they often don't access any services except the emergency room. So what we know is that people who inject drugs primarily access in an emergency room. This is all over the place. And what we know is that by the time they access in the emergency room, they're very sick. And so, Corinna, you talked about two, like sepsis and wounds and stuff, but the other really prominent thing we see is pneumonia a lot, particularly folks who are impacted by homelessness because they have higher rates of respiratory, 30% higher rates of respiratory illnesses. And so we see them accessing the emergency room. So lots of harm reduction programs are meant to say who is mostly accessing the emergency room and how do we get them accessing in harm reduction over here, where we can link them directly to clinics and directly to doctors to free up our emergency rooms. Because what we know is that for some folks, once they're really sick, they will access almost every single day in that emergency room. And so what that means is that it then ties up emergency services, so that not everybody is getting, and already our emergency rooms are bursting at the seams, right? And so that, and then once they're linked into harm reduction, we're able to get them off to those doctors so that they can start to build relationships, and then they can get treated when they have a cold versus getting treated when they get a pneumonia, which is over here in the emergency room. So we do definitely see better outcomes for folks, including better linkage to treatment if there's treatment options, or better linkage to like AFM when you have an AFM worker locally in the community. So, yeah. Sorry.
Okay, so you're saying that your harm reduction, that they're trying to eliminate from the emergency room. So you're saying that the harm reduction here in Swan River provides those services to their peers to act so they don't have to, they access the doctors more so than an emergency?
Yeah, so for example, public health, when we first started to do work here, we worked directly with a public health nurse. And that public health nurse came up to all of our events. She had no relationship with the peers at all. And we got her coming to our events to build relationships with them and say, this is who the nurse is. What do you need to do to trust her, to be able to access her services? She started to do some outreach with the peers. She then moved over to another clinic, and now those peers access services over at that other clinic because they trust her and have a built-in relationship with her. So our intent is to say to peers, who do you need services from that you're not currently accessing? And is there a way for us in harm reduction to start to bridge that? So that eventually, the hope is we work harm reduction out of the community because folks who use substances have built-in relationships with those service providers to be able to access directly from them. We're not there yet. That's why we have lots of folks who won't go to the hospital, lots of folks who won't go to the clinic, lots of folks who won't go to AFM, for example. So how do we start to build that connection?
Well, and we also don't have the services for these people. We don't have any kind of addictions. We have nothing. So my only question is, we provide the needles, but where does it go afterwards? You know, we're not providing them with any kind of afterwards. Like, okay,
Oh, yeah.
do you know what I mean?
Absolutely,
There's nothing.
Tanya. There's nothing.
There's nothing. So I think that's for a lot of people. Okay, we're providing needles, but there's no after outlook for them after. So that's probably one of the biggest problems that we are encountering.
Well, and what we know is that we're providing the needles, but for lots of the folks, they're also now starting to get access to other healthcare services and mental health supports that they previously weren't. We don't have treatment. Like, I would love to spend time going through what treatment actually looks like in this province, but because we don't have that, it's about what do we actually have in the community, and then how do we advocate for those pieces that are missing, because we really need a robust mental health system in our province. And I want folks to know that out of the provincial budget, 2% of the provincial budget goes to mental health. So you get what you pay for. Like, what are we going to get with 2% of a budget? And most of that stuff is in Winnipeg, right? So what does that mean for Swan River? What does it mean for Thompson? What does it mean for Flin Flon? We know that there's even less services up here.
Councillor Whyte.
Now, first, I appreciate everything you say. That makes a lot of sense to me. But I'm just looking at some of those numbers, and I see 300,000, 500,000 in the last 2 years post-COVID.
300.
300, then 500. The last number we were given was 500,000.
Oh, for needles
needles
distributed.
distributed.
Okay,
We went to
okay.
800,000 needles in 2 years, so I'm sure there's an answer. So somehow, if I'm a drug addict, I have addictions, obviously, in different degrees. I come to get the needles, and I need those needles, or I'm hooped. Why don't they have to bring back the used ones?
Excellent question.
You know, bring them
Yeah.
back, or you don't get any more. Welcome to the real world.
Yeah, and so needle exchange programs have been, like most people who use needles have their own disposal mechanisms. So if 500,000 needles were given out, there certainly wasn't 500,000 needles found in the community. We know that the majority of folks have safe disposal mechanisms at their duty. The folks who don't have safe disposal mechanisms are those folks who use substances outside. And so when we say, can we bring them back, lots of folks aren't even holding on to them, as you guys know and as you guys can see, which is why we also wanted to, and we launched those little black individual ones, because they can hold up to 10, and then people can throw those in the garbage or take them to public health to be discarded. But the research is showing, and the evidence shows, that needle exchange programs are not a best practice model. It is something that has been explored many times, but because many people already have their safe way of disposing of needles, to bring some back doesn't make sense because they've already disposed of them in a safe way.
But this model isn't
That's some
working
folks.
either.
Now we're talking about the other folks, that how do we get folks to bring needles back if they are, and it's important to note that we have some needle drop boxes in certain areas, but what we need to look at is where are people actually using substances publicly, and how do we put needle drop boxes in those areas. So for example, one of our more recent examples is in Montreal. There was a park where lots of needles were being found, and they did a long time of trying to shoo people out of the park, and they put security in that park, and it didn't do anything to reduce publicly discarded needles in that park. And so what Montreal did is they put 2 needle drop boxes, just small little black boxes that are on a wall on each end of the park. And from that, they saw a dramatic decrease in publicly discarded needles. So they just went to where the hotspot is. If we want to even think about locally, there's a community, I don't want to stigmatize that community, but there's a community that saw a whole bunch of discarded needles along the riverbank, which is where people were publicly using substances. And so that community then spent a long time trying to get people to move away from the riverbank there, and it didn't work, and they still continue to see publicly discarded needles. And so they put a needle drop box they put a big box right on the path, and they saw a significant decrease, so much so that that needle drop box gets emptied twice a week, because people, once there's options for needle disposal, people dispose of them. Brandon had a situation where they had a bush where they found a whole bunch of publicly discarded needles around that bush, and they cut the bush down and put a needle drop box there, and then it reduced publicly discarded needles. So it's a matter of saying, where are people using them, because that's where they're going to dispose of them, and how do we move that? But ultimately the goal is how to get people indoors so that people aren't publicly using drugs, because even if we don't give out any supplies, let's say public health also stops giving out new needles in this community, will there be a decrease in publicly discarded needles? Do we think that will actually happen?
So have you identified the hot spots in the Swan Valley community and put these drop boxes up, and if so, how many?
As many as where people are using.
How many are put up?
Oh, how many are put up? Well, there's a few places that I'd love to go right now and put some boxes for you folks. When we're doing our needle cleanup, we're looking at hotspots where we know people are publicly using, and so we want to think about, if we're finding 14, 15 needles there, can we put a drop box right there on the pole?
Have they done that here?
I think the Sharps Committee.
A meeting tomorrow, and they will have some data on exactly those hotspots that you're asking about.
Yeah.
Councillor Boychuk, and then CEO Poole, and then Robin.
I guess so. For talking about that specifically, like putting up a box where there's a hot spot, for instance. Well, some of the hot spots, unfortunately, are, I guess, in an area where young children are coming and are taking in. I just don't personally feel that this is something that the youth in the community need to be bombarded with, I guess, absolutely, at their age. Yeah. So that bothers me, that we're trying to make this a normal situation in the community now, and I feel that I guess I would rather, instead of promoting non-public drug use to decrease public discarded needles, why are we not advocating for the promotion of no drug use, period? Mm-hmm. That seems to me to be more of an initiative that I would be behind supporting, and keeping these individuals, or providing individuals or enabling them to keep doing what they're doing that is really not doing anything positive for their existence, their life, is questionable. Why so much effort is being put into keeping people using drugs, but in a hopefully safer way, so that they don't cost our health care down the road. It's just questionable in so many aspects, and I don't know. I think I've heard something about 4 pillars, and really truly we have one here, and we're really seeing, I guess, the evidence that one is providing more harm to the community than it's supposed to be helping this situation. And from that other meeting we had with the doctors there, if I'm remembering correctly, Swan River has a disproportionate higher amount of HIV individuals in our community versus, I don't even know what they were comparing it to, Winnipeg or all of Manitoba. I'm not sure what the comparison was. But to me, my question is, the stats on the peers in our community, how many peers are there? Do we have a number? If we're saying the Parkland area or whatever, or Swan River, what was the needle? There's been so many numbers. It was first 250 or 300, but then they corrected that Parkland was actually 500 and it's this area and whatever. Like, how many peers are requiring that type of access to needles? And really, the exchange program, I think what we're lacking in this day and age is the accountability. We're lacking accountability on so many fronts, whether it's the education system, it's the justice system, it's our own healthcare system, it's housing. If you don't have accountability for one's actions, how is anything ever going to improve? If you keep allowing people to make the same mistakes over and over and say, well, that's okay, here's more. You know what I mean? This isn't working. Nobody's learning. There's no change. We're keeping people at a level of meager existence that is no good for anyone. It's no good for those individuals. It's no good for the individuals around them in the communities that they're living in. And as far as like the exchange program, I think is great. And I mean, obviously we're not seeing 500,000 distributed in our community, but guess what? Those ones that aren't, if you don't bring those 10 back that you got, you're not getting 10 more. So how can that not work? At the end of the day, where are you getting them from? If you're not getting them from there, are you going to go buy them? I don't know where they got them before we started handing things out for free. And then the other thing with that is when you're doing that exchange program, to me that seems like a better situation because that's more frequent interactions with the peers and the support workers. So you're building those relationships quicker, faster with the outreach and potentially having a higher success rate with linking those peers to those different supports. Those are just some of the things. I don't know. I have like tons of.
You had a lot of questions there.
Tons
So
I know, and that's
let-
okay.
let
Where do I
that-
start? First of all, I want to be clear, we absolutely agree that young people, nobody should be experiencing public discarded needles in any communities. Like, we absolutely don't want to see that. Even our teammates who work in this community are raising their kids in this community as well, and so they definitely, nobody wants publicly discarded needles. Okay, what was your next thing? When it comes to, what was it? The frequent connections to services.
Yeah, the exchange, yeah.
Yes, and so what I want to be clear on, you asked about the number of peers. So we at the Manitoba Harm Reduction Network have, I can't give you the exact number for this year, but I think last year there were about 83 different people who were engaged. Who we actually directly work with is a group of 20 peers who they themselves do everything they can to reduce publicly discarded needles. So they also are part of our cleanup crew, cleaning up needles. They are also very clear they do not publicly discarded needles. They have their own mechanisms to do that. And out of those 20, when we now host our events, we have about 63 additional peers from Swan River that attend those events. There's way more than that in the province, or sorry, in the community that we don't know. And we also have seen, as we were hosting our testing and treatment events, our coordinator here reported meeting new people. So I don't know if that's new people to the community or if that's new people that we just have never met yet. So we have the folks we have access to, and then Prairie Mountain has a group of folks that they have access to that don't come to us. But Prairie Mountain doesn't necessarily, like, they have their own services that they offer to those folks. We are offering services directly to folks who are very, very rarely accessing public health. Our goal is to get all of the 83 people that we're engaged with directly accessing those services so that we eventually have them, because if, for example, they show up at the PCOC clinic, not only would they get support around their substance use, but they'd get support around their diabetes, they would get, like, all of those things are in that building, and vaccines and whatever the heck else they may need. And so the goal is to take the folks that access our services and eventually have it so that they're all accessing here. But we are seeing an increase, very much, like where some of our sites will get 1, maybe 2 new peers every couple months. We're meeting new people quite frequently. And then even as supply distribution changed in this community, one of the sites stopped doing supply distribution and many of their peers started to come to us and we didn't know them. And then when we stopped supply distribution, now we're referring all of those peers over to public health. So when you ask how many folks, I don't know, but what I do know is that at one point when people were housed, we were supporting about 80 people that were housed with connecting them to services. And even some of those folks now that they're unhoused, we don't even have access to all of them anymore. So yeah, it's
We're running out of time, and there's about 3 other people
Yes.
that want to speak, so I'll go to
I don't know if I
Poole,
answered all your
then
stuff.
Bobick, and then Whyte.
So I'm going to introduce, just get to my question, but the town of Swan River, the problem, you've said it yourself, we're going to get there. It's going to take time to fix the whole wraparound services, and finally the province is acknowledging the Glasgow crime project. I've done a lot of research on that, on John Carnish, the guy who started it, the
Yes.
old police chief. Manitoba is finally doing that. He travels the world now explaining how to do this properly.
Yes.
So we will get there. The CSWB, the province is getting there, but we know it's going to take a lot of time. My question is, if we know that, like if we've established that wraparound services aren't there, there's massive holes all the way around the wheel,
Yeah.
why is the supply and distribution, the one that we are doing, hit so heavily? It's redlining so that, like, let's be honest, we're here because of needles.
Yes.
And that program is redlined, and it's ramped up so heavily. It's the one, I know we're doing more than one thing, and everybody's trying.
Yes.
But why is that system absolutely at 3,000 RPM when everything else is at 0? Why aren't we just stop and see what we can do with resources so that we can get 30% of everything running instead of 10,000% of this supply and distribution and absolutely nothing on mental health?
Yeah.
You need.
So what I want to say about that, like, because we absolutely need to build wraparound services, that is really key. And you talked about the 4 pillars. Harm reduction is one of them. Policing has always been one of them as well. That's the other one that you guys absolutely have in your community. We have it in all of our communities. But we do want to build these wraparound services. When we talk about supply distribution, what we actually know is that we're actually not even meeting the need there. So this notion that it's ramped up to 3,000, and I want to be clear, those numbers are going to potentially come down because we had a satellite site program that also included a bunch. So us, for example, last year we gave out 150,000 needles. This year we're less than 20,000 already, only because we no longer have houses where we were doing larger distribution sites too, right? So for MHRN, the numbers were always going to go down. For Prairie Mountain, and remember there's harm reduction and then there's supply distribution. Those are 2 different things. From a health perspective, and this is where I hope the doctors and stuff are clear, is that for them it is a matter of interrupting HIV and Hep C transmission. So that's what their goal is. Over here in harm reduction, our goal is absolutely how do we build wraparound services. That's exactly what that health fair, for example, is designed to do, is to bring all the players to the table. But I also want to be clear, this is not a Swan River issue. This is what we are seeing, an increase in substance use. We're seeing an increase in, or decrease in services that people need, because even if we just think about healthcare, our healthcare system right now is in extreme crisis. And so, yeah, so we are in the same boat where we want to ramp up all the things. I want to be clear, I want us to think about, like, what happens if MHRN just disappears? And we currently, I feel like I want to say 120 is our number this year, 83 was our number last year. We currently provide services, are connected to 120 people. What happens then if we leave? So we're already not doing supply distribution, but we also leave and stop doing some connection to those services. What would then happen to those folks? And what we know will happen because of all of those holes you just talked about in services is those folks are going to transition to the emergency department, which is what we have found everywhere else. And so now it's a matter of, now what do we do with an emergency department that has people waiting outside to get in? And things like sepsis and things like pneumonia take priority. So what happens to other folks who are showing up at the emergency room? And we have already witnessed this in Winnipeg with our emergency room, which is why people are waiting 25, 26 hours to get care. And we started to see this also happening in our smaller communities. We also have emergency rooms that, because of busting at the seams, have had to shut their doors. And we've all heard the stories about emergency rooms being closed as well. So we're on the exact same boat. The whole intention of us coming here is to say, how do we link these people to get them wraparound services? Because currently right now, there's healthcare, and many of those folks that we work with don't access that healthcare system until they have to access the emerge.
So it's cheaper to buy, I don't know what the biohazard collection bins than to have the beds filled with the hospital.
Well, the beds
I know
for the
that
hospital,
The doctors talked about that, is
Yeah.
ultimately, in the end, it comes down to money. It's cheap, like, because we always have the question,
Yeah.
why are we doing this on the back end and collecting all these things? Get it at kilometer 1 instead of kilometer 4.
exactly, yes.
But and there is a piece to that, including John Carnishin's deal.
Absolutely.
But for now, I think the doctor said it was $63,000 per, I don't know if it was a week or a night. But I can't remember the number, I shouldn't quote me on that, but
For a hospital stay?
yeah, the hospital stays are much more expensive than buying a collection bin for now. It doesn't mean that
Yes.
it's going to be the
Yeah.
house.
Well, and the reality is we can't have one response. Like, the number one thing we have to, if we want improved outcomes for people, the number one indicator of health is housing. That's it. And if we can house people, then we can start to address their other needs. Housing is our number one, any of us as human beings, the shelter is our number one basic need that we need to meet. And there's so much research that shows that once we house people, then we can actually start to address their complex needs. And I want to be clear, when we're talking about the folks that we work with, it's not a simple problem, right? Like, substance dependence is very much connected to trauma, it's very much connected to mental health, it's very much connected to all of those things, which means because it's complex, we need a complex response to be able to address it and support what folks are going through. The alternative is just folks wandering the community without supports. And so what does that then translate to? And we're in a time when, due to inflation, manufactured poverty has increased, which has led to more people being impacted by homelessness as well. So, and that's across the country as well. So we everywhere are seeing a spike in homelessness. So how do we address that?
Councillor Bobick and then Whyte.
Does harm reduction work anywhere where there isn't free meals?
So I want to be clear again, there's harm reduction and then there's
Yeah.
supply distribution. So harm reduction works. Harm reduction is about taking folks who are the most marginalized and connecting them to services. Supply distribution, so there has never been a situation where we started supply distribution that we didn't first identify that there was an increase in HIV and Hep C transmission due to due to injection drug use. So there's always been a spike in HIV and Hep C, and then we came in and said, we got to stop HIV and Hep C from being transmitted in that community. That's why supply distribution itself is solely a health intervention to prevent the transmission of HIV and Hep C. So what was your question again? Let me make sure I answered it, Don.
I asked, does harm reduction work anywhere where there isn't free needle distribution?
Yes, because harm reduction can happen without supply distribution.
So you could have harm reduction in the town of Swan River, but you could have so there would be no needles distributed.
Yeah. And because harm reduction can happen without needle distribution. Like, that's about engaging people who use substances.
Does harm reduction work with other entities? I'm going to use Team Challenge as an example. Do you work with other entities that deal with addictions?
Sorry, do I work with other entities that?
Yeah, like, I'm thinking Team Challenge, stuff like that.
Yeah, harm reduction, there's lots of harm reduction programming for youth. What we know is that youth ages 15 to 24 are the group that are going to use the most amount of substances in any given time, whether that's alcohol or cannabis or other substances. And so there's lots of harm reduction strategies to talk to young people. And we definitely start with messaging, don't use substances. And if you're going to use substances, we want to talk about how you can be as safe as possible if you're going to use.
So has there ever been a thought of a deposit on the needles so they could return it and get money that way instead of?
Yeah, there has been some discussion about that.
Instead
How
of
do
paying
people-
people to pick them up, why wouldn't they just bring their own needle
Yeah.
back and receive the money?
Yeah.
Councillor Whyte.
That's
So 500,000 needles went out last year in the valley.
Yeah.
Apparently, nobody records who got those needles. Now, if there's some sort of data, hard baseline data, why would they give that many away if we've got 100 people using drugs? Somehow, I'm not blaming, I'm just wondering, how can we give 500,000 needles out and not know who they're going to?
Where's the
20,000
narrative that we
needles in
don't
the
know?
house.
Like, we know exactly who we provide needles. We know exactly who we provide.
I don't need the
needles
name,
to.
but
No, so I'm saying, so where's the narrative? I don't know where the narrative is that we don't know who they are.
The harm people who sat right there told us they did not record where they went. And we have a house that was taken down by health.
Yeah.
20,000 needles in that house?
22.
22,000 needles in one house. Why would they keep taking them, delivering, I'm assuming they delivered them, to that house?
Well, and what they also did, and I don't want to speak for Prairie Mountain, but what I do know is that in addition to dropping off needle drop boxes and dropping off new needles, we also collected the full sharps containers. And then we took them to have them discarded with public health. And so there was a mechanism to collect those needles. So when the house was closed down, if there were a bunch of needles in there, it was because we didn't get a chance to go collect those needles yet. But we had a mechanism where folks were trained in transportation of dangerous goods, and then they transported them.
But I believe your harm staff who sat here said they did not record the names of the people that gave those needles to, because that was violating their privacy.
Yeah, so we don't record the names of the people we provide them to, but we know who we provide them to because we see them. So we know who we're providing needles to, but we don't collect the data on who's getting what. Just like we wouldn't collect the data on who's taking condoms, right? We don't collect that data. But what we can tell you is this many people access harm reduction supplies from us. That's what we can tell you. But we don't, and I can even tell you that we do collect like some demographics and stuff on the folks that we provide services to, but not all of them necessarily, not everybody we provide services to actually access supplies.
But somebody should know, there should be a number rising up. Holy smokes, we're at 200,000. We're not giving any more needles out. Who's aware of that 500,000 number approaching quickly?
Prairie Mountain Health will know. When we did do supply distribution, we reported every month what we gave out and to how many people we provided
So do
services
they add
to.
infinitum? Do they just go forever?
Sorry?
Do they give 1 million away then if there was? I can't understand how anybody, any institution can give
Yeah.
500,000 needles out in 1 year in this town of 4,000 people, and nobody said, no, that's enough. Because that's a problem, all those stupid ass needles are running around.
Well, and the 500,000, my understanding is that went to the valley,
Yeah.
right? Like not just Swan
Small
River.
valley.
Yeah. And so what you're asking is there a cap? Like, is there a time we say
Well,
that's
we
enough
think-
needles to give up?
I would volunteer.
So I'm afraid that we had a really good
Okay.
discussion and went really fast. It was really speeded up in the last little bit, but we do appreciate you coming in. I'm sure councillors have an opportunity if they need to email or call you
Absolutely.
anytime
Yeah.
to have any further discussion. One of the things that you did say that I think is important, that you said that harm reduction has ended the needle distribution here in the last month, correct?
Yes.
Yeah, and that's what I was told as well.
Yeah.
The other thing that you said is there's little treatment or no treatment that's available in the province, and I heard that from the federal minister, and I think we also heard that from the provincial minister, that there is not that opportunity for individuals to find that help. One of the last things I want to say is that there's a lot of people here in Swan River, residents that live here, that think that this program, harm reduction, because they'll put harm reduction with needles no
Absolutely.
matter what, okay?
Yeah.
We could talk, blue in the face about this whole thing, but there's a lot of people here that think that the town of Swan River runs this program, and we are the ones that are responsible for that. I had a discussion with somebody last night that was adamant that we are. And this is where I talked to the CEO for Prairie Mountain Health, I talked to some maybe from your own people in the offices, or even with CMHA, to have some of these town discussions, because there's a lot of people that don't understand. You can sit here and talk to us, and we can make that understanding and make those connections, but there's a lot of people that won't look for that. And I think that they need to be educated on some of the things that you are doing in the community, other than just needle distribution.
Yeah. I agree. There's lots of misconceptions about what we do. Like, we heard narrative of we teach people how to use illegal drugs. We definitely don't do that. We promote drug use. We absolutely do not promote drug use. We actually promote people changing their relationships with their substances. And so, and our outcome, our ultimate goal is for people to have better outcomes in their life. And that means for many people reducing their substance use. But I also, I know I have to go. What I do want to tell you guys is that I work in this field. I work directly with people who have diagnosed substance use dependence. And in my 17 years of being here at this network, I have, and my years prior to that, where I worked at Sage House in Winnipeg and worked with people who also had problematic substance use, I have never once been able to have somebody come to me and say, I'm ready for treatment right now, and actually get them into treatment. And I want folks to know that, because I work in Winnipeg where there's detox in Winnipeg, and I can't even get people directly into treatment. And so it is a real alarming concern for us, because as we start to see substance dependence not increasing, but we're seeing more harms related to people's substance use. We're also seeing an alarming number of overdoses, which is the #1 cause of death right now in our province. When we don't have a system, for those of us who even work in it, to get people directly into treatment, that's a big red flag for us to say we absolutely need investment in that. So I want folks to know, like, that is our ultimate goal, is for people to have good outcomes in their life and reduce their substance use. We need a system that's conducive of that. So.
Okay, well, thank you very much for
Yes,
coming.
thank you, guys.
And we'll be talking, I'm sure. Again.
Yes, I will make sure you have my email if anyone, oh, you do have my email.
I have your email and I have your cell number as well. We text back and
Yes,
forth. So
yes, thank you.
I appreciate you responding as well.
Thank you, everyone.
And you're not driving home tonight,
No,
are you?
gosh, no. I'm gonna enjoy the snow. I love winter, so I'm gonna hang out and enjoy the snow. Hopefully it's not snowing by the time I do go home and want to
Yeah.
drive it.
Okay, take
Thank
care.
you, everyone.
Yeah, good night.